Welcome to this explainer. Today, we're tackling the clinical reasoning behind abdominal pain. For far too long, the acute abdomen has been treated as this frustrating exercise in rote memorization, just blindly matching a laundry list of diseases to isolated symptoms. Well, we're completely flipping the script. We're shifting to a true first principles approach. We're going to map out the story of the abdomen step by step, so the diagnosis literally reveals itself logically every single time. Let's get right into it. Here's our roadmap for the explainer. We'll start with the two types of pain, move into embryology and mechanisms, look at the rules of radiation, explore surgical and medical causes, and wrap it all up with a 5-step framework.
Starting right off with Section 1, the two types of pain.
So fundamentally, every single abdominal pain you'll encounter originates from one of two places. First up is visceral pain. We're coding this as blue. It originates right within the organ itself. It's dull, it's diffuse, and it usually sits smack in the midline. We have to contrast this with somatic or parietal pain, which we're coding as red. This happens when the lining of the abdominal wall gets irritated. It is sharp, severe, and very precisely localized. Grasping the split is absolutely crucial. It's step 1 in our framework. Moving right along to Section 2, let's look at embryology and mechanisms. This actually brings up a really fascinating question. Why is visceral pain almost always felt directly in the midline of the body? Even when the organ itself sits way off to the left or the right. Well, the answer goes all the way back to before we were born. Our abdominal organs actually begin their developmental journey right in the embryonic midline before rotating out into their adult positions. Because they start in the center, they receive bilateral autonomic innervation, meaning nerve fibers from both sides of the spinal cord. So when an organ is stretched or inflamed later in life, these bilateral signals travel up to the brain. The brain gets these overlapping signals, and honestly, it just gets confused. It can't accurately pinpoint which side the pain is coming from, so it defaults to perceiving a diffuse midline ache. It's literally an embryological echo. Now let's apply this to a classic medical puzzle: acute appendicitis. Why do patients almost always say the pain starts near their belly button, but then a few hours later, it seems to move to the lower right side? Here's the secret. The pain doesn't physically move at all. It starts with an obstruction in the appendix. That triggers our blue-coded visceral pain, which the brain perceives as that dull midline ache we just talked about. But as the inflammation physically expands outward and eventually touches the abdominal wall, a totally different sensory pathway fires up. That's our red-coded somatic pain. Boom! Now the patient feels a sharp, well-localized pain exactly where the appendix actually sits. The pain didn't move. The inflammation just expanded into a new sensory territory. All right, beyond just the type of pain, there are 4 fundamental physiological mechanisms that drive nearly every abdominal condition you're going to see. First is stretch or distension. This produces colicky pain as internal pressure builds up. Second is inflammation, which, as we just saw with the appendix, transitions from diffuse to localized. Third is ischemia. When tissue is deprived of oxygen, it releases inflammatory mediators that cause incredibly severe pain, often way out of proportion to what you find on a physical exam. And finally, smooth muscle spasm. This is when an organ forcefully contracts against a blockage, sending pain in intense waves. Pinpoint the mechanism, and you are halfway to the diagnosis. Next up is Section 3, Rules of Radiation. You've probably heard about patients feeling pain in their shoulder when their gallbladder is acting up, or pain shooting into their back when their pancreas is inflamed. But why exactly does pain radiate so far away from the diseased organ? The secret here is shared spinal cord segments. It's basically crossed wires in the nervous system. Take the gallbladder, for example. When it gets inflamed, it can irritate the diaphragm, and the diaphragm shares a nerve pathway with the shoulder. The brain gets completely confused by this shared wiring and projects the pain all the way up to the right shoulder. It's the same story with the pancreas. Since it's a retroperitoneal organ sitting in the back of the abdomen, its inflammation signals share segments that refer pain straight to the back. And a kidney or ureteric stone, that pain literally tracks the migration of the stone, referring from the loin right down to the groin. So referred pain isn't some random quirk. It follows a very precise anatomical map. Okay, let's move on to Section 4, surgical and medical causes. Let's see these rules in action. Let's compare peptic ulcers. The classic difference between a gastric and a duodenal ulcer isn't the type of pain, it's the timing. With a gastric ulcer, eating food stimulates acid secretion, which immediately bathes the ulcer and makes the pain worse.
But with a duodenal ulcer, eating food temporarily buffers that stomach acid before it empties into the duodenum, which actually gives the patient temporary relief. As you can see, the underlying physiology perfectly dictates the clinical symptoms.
Moving down the GI tract, let's look at acute pancreatitis. In this condition, premature enzyme activation causes the pancreas to effectively digest itself. This autodigestion triggers severe epigastric inflammation. And remember our rules of radiation? Because the pancreas sits retroperitoneally, it perfectly explains that classic radiating back pain. In really severe hemorrhagic cases, that retroperitoneal blood can even track to the umbilicus, causing Cullen sign, or out to the flanks, causing Gray-Turner sign. Next, let's contrast two gallbladder states that are super easy to confuse. Biliary colic is a temporary obstruction. A gallstone gets stuck, causing waves of intense colicky spasm, but then it falls back and the pain eases. Compare that to acute cholecystitis. Here, the obstruction is persistent. It doesn't move. This leads to continuous orange-coated inflammation of the gallbladder wall. The pain stops being colicky and becomes a constant ache. Plus, this localized inflammation gives us a classic positive Murphy sign, where the inflamed gallbladder hits the examiner's fingers during deep inspiration, causing a sudden, sharp catching of breath. Now let's trace the progression of diverticulitis in the colon. It starts innocently enough with a normal sigmoid diverticulum, but then the neck becomes obstructed. Initially, this might just cause some intermittent smooth muscle spasm, that colicky pain. But as it progresses to localized inflammation and then expands into pericolic inflammation hitting the surrounding tissues, the character of the pain transforms entirely. It becomes a constant, severe left lower quadrant pain, usually accompanied by fever and raised inflammatory markers. We also have to be incredibly vigilant for vascular catastrophes, primarily the abdominal aortic aneurysm, or AAA. I really want to emphasize this. AAA pain is severe and constant precisely because the retroperitoneal aorta lies directly anterior to the lumbar spine. When it rapidly expands or ruptures, it violently stretches those retroperitoneal tissues. This presents as sudden, severe back or abdominal pain combined with life-threatening hypovolemic shock. It is a true, massive internal hemorrhage emergency. So what happens when the bowel itself is physically blocked? Well, early on in a mechanical obstruction, the smooth muscle violently spasms against the blockage. This creates intense colicky pain and those classic high-pitched, tinkling bowel sounds. But as gas and fluid accumulate, causing massive distension and vomiting, the bowel muscle eventually just fatigues. The clinical picture shifts dramatically in late obstruction. The abdomen becomes massively distended, and those hyperactive sounds transition to a completely exhausted, silent bowel. Now, a vital word of caution here. Not all abdominal pain actually originates within the abdomen. We always have to consider extra-abdominal medical causes, especially when a patient is in absolute agony, but their physical abdominal exam is relatively soft or benign. Things like an inferior myocardial infarction or a lower lobe pneumonia can easily irritate the diaphragm. Diabetic ketoacidosis can cause severe metabolic bowel irritation. Even rare conditions like acute intermittent porphyria or lead poisoning can manifest purely as severe abdominal pain. The takeaway? Always keep your differential broad. To tie all these specific pathologies together, you can see that instead of rote memorization, we just need to match the primary mechanism to a classic clinical clue. For instance, if the mechanism is acid exposure and the clue is pain worse after meals, well, that's a gastric ulcer. If the mechanism is progressive inflammation shifting from the center to the lower right side, that's appendicitis. This kind of physiological matching is just vastly superior to blind memorization. And that brings us perfectly to our final section, the 5-step framework. When evaluating abdominal pain, you can walk through these 5 fundamental questions to build your clinical reasoning structure. Step 1. Is the pain visceral, diffuse, and blue, or is it somatic, sharp, localized, and red? Step 2. What is the primary mechanism? Are we looking at stretch, inflammation, ischemia, or spasm? Step 3. Based on the location and that mechanism, which organ best explains the pattern? Step 4. Does the pain radiate following a known neural pathway, like up to the shoulder or straight through to the back? And finally, step 5. What associated symptoms, like vomiting or shock, logically follow? Answering these specific questions transforms abdominal pain from a frustrating memory game into a masterful physiology-based framework. This brings us to the end of our explainer. I want to leave you with this final provocative thought. Next time you encounter the acute abdomen, whether you're working on the wards or just studying the human body, will you rely on a memorized list of symptoms? Or will you follow the physiology, ask the right structural questions, and let the true diagnosis reveal itself? Thanks for exploring this with us, and we'll see you next time.